This is the endocrine lecture, and I may divide it into a couple of parts, but this is part one, and my hope is that you're going to love the endocrine system as much as I do, and it's a lot of facts, but we're going to learn all the facts and then how it integrates. And so this lecture on the YouTube, I want to be just data, and then in class we'll kind of put it all together. And the outline will be, number one, I'm going to tell you some data and some definitions. Number two, just list the organs of the endocrine system. And number three, the disorders that happen with these organs, and some of the tests and the meds and the treatments, both nursing and medical, that are involved. And so, starting with just some data and some definition, I want you to know that when we say endocrine, C-R-I-N-E, crine means secrete. And we have exocrine and endocrine. And exocrine is when there's secretion from a duct, like the GI tract, the pancreas and the GI tract, enzymes come through a duct, D-U-C-T. It's endocrine is when secretion is done through the bloodstream, like the pancreas and the islets of Langerhans secrete insulin through the bloodstream. So we have endocrine and exocrine. Exocrine through ducts, endocrine through the bloodstream. I want you to know that cortex means covering. C is a way to remember it. The medulla is the inside of something, the medulla. And then I just want you to know that the word ortho really doesn't have to do with this system, but people don't realize ortho means straighten. It doesn't mean bone. It means straighten. And then myo, M-Y-O, means muscle. So when you see these prefixes, you'll automatically know what they mean. I want you to remember that the islets of Langerhans are on the pancreas, and that those islets secrete insulin, and they go to the bloodstream. And then the rest of the pancreas secretes 4 enzymes, if you recall: amylase, lipase, pepsin, and trypsin. 4 digestive enzymes, and they're produced and go through a duct to the GI tract. The pancreas is probably our only organ that is both exocrine and endocrine. And I think you know the islets of Langerhans that secrete insulin have nothing to do with the digestive enzyme part of the pancreas. They just live together, but they don't have anything to do with each other. The baby's body has about 70% water, and adults have 50% water, makes up our bodies. And hormones may be included as proteins, peptides, or steroids. And I wanted you to keep in mind prenatal vitamins have more minerals than a multivitamin. And that's good to keep that in mind. When the body lacks a hormone, we have a system, and it's the endocrine system, that helps make sure that area is attended to. There'll be more words I want you to learn throughout, but those are the main ones at this point. Number 2 on our outline is list the organs. So let's just list them. You have the hypothalamus, called the master gland. You have the pituitary, whose other name is hypophysis, Hypophysis, hypophysis. Know both names, pituitary, hypophysis. It's divided into anterior and posterior. We'll talk about that. Then the pineal or pineal gland, Pineal, pineal gland, the thyroid gland, the parathyroids, the adrenal gland, the thymus, and the pancreas. And those are the organs that we're going to talk about in this study of the endocrine system. So going back to the hypothalamus, it's about the size of a prune, and they call it the master switchboard. About the size of the prune, base of the brain, and it has the richest blood supply in the entire body. Blood goes to the hypothalamus, and the hypothalamus decides whether a certain area is a little low in sugar, or it's a little low in cobalt or zinc, and triggers either the production of a hormone or itself stimulate that area so that it's sufficiently taken care of chemically or hormonally. The hypothalamus coordinates with the chemicals or hormones. It coordinates our nerves, our muscles, as with these hormones, so that we have this harmonious operation of nerves and muscles. It does produce two hormones. The hypothalamus, besides being the richest blood supply with a major switchboard, it produces two hormones. One is Pitocin, 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 which has to do with contracting of the uterus. The second one, the second hormone is antidiuretic hormone, and it is just what the words say, anti-diurese. Keeps us from diuresing. And otherwise, we drink and it just flies through us. But our body is so beautifully orchestrated, it knows how much to put out to hold water so it can gather waste to take out. The antidiuretic hormone and Pitocin are made in the hypothalamus. Then they come down a little stalk, and they come down to the posterior pituitary or posterior hypophysis. And you might as well learn the name of the posterior hypophysis. It's called neuro, N-E-U-R-O, hypophysis. So when you hear neurohypophysis, you know it's the posterior part of the pituitary that's storing Pitocin and ADH. They store them. Made in the hypothalamus, stored in the neurohypophysis. And then the anterior pituitary is called adeno, A-D-E-N-O, adenohypophysis. I think A, anterior, adeno is the anterior. And it has lots of hormones. It doesn't just store two like the posterior. Now, posterior and anterior don't have any connection as far as talking to each other or working with each other. They're just neighbors. They're just neighbors. And so coming off the anterior pituitary or the adenohypophysis is the growth hormone, or the somata. Soma means body. The somatotrophic hormone. And it has to do with our growth. And if you have a large amount of growth hormone that is produced early in life, then it might be that you have gigantism, G-I-G-A-N-T-I-S-M. Growth hormones poured out pre-adolescence, so you grow very large. You're not disproportionate, you're just extremely large. If growth hormone starts pouring out in adulthood, it's called acromegaly, A-C-R-O-M-E-G-A-L-L-Y, A-C-R-O-M-E-G-A-L-L-Y, acromegaly. And it pours out, for whatever reason, after pubescence. And in that case, your long bones get longer, and some of your features where there's cartilage, then it grows and changes your appearance. And it's after pubescence. If you're a child and have too little growth hormone, you are just small. You're not the politically incorrect term midget or dwarf. You're just a small person, small people, like a jockey. Jockeys are well proportioned, and so the midget or the dwarf is disproportionate. Their head sometimes is adult and their body is small. So keep in mind, growth hormone is systemic. It's happening throughout the body, not just one area. So you're just small people. That's the growth hormone. Melanocyte-stimulating hormone has to do with pigmentation. We usually have all that established by adulthood, so it's usually, I don't even think your book mentions it, melanocyte-stimulating hormone, melanocyte stimulating hormone. The thyroid-stimulating hormone is not your thyroid hormone. Remember, it's the stimulating hormone from the anterior pituitary that stimulates the pituitary gland to produce T3, T4, and calcitonin. And when we take each organ in a few minutes, we'll talk more about those three. But that's the thyroid stimulating hormone, not thyroxine, not T, not T4 or 3, but thyroid stimulating hormone. We have the gonad meaning reproduction, the gonadotrophic hormone, and they, if you'll just learn the name, just what they are. You don't have to, FSH does this, ISH does this. If you'll just know them, they're under an umbrella. Luteinizing hormone, I think they sexual secondary characteristics, follicle stimulating, interstitial cell stimulating hormone, ICSH, prolactin. They are your gonadotrophic. They have to do with keeping our reproductive system alive and viable and functioning properly, the gonadotrophic hormones. Then we have ACTH, which is adrenal cortico-covering trophic hormone. Adrenal glands are the little caps that sit on top of the kidneys. Again, they have no relationship with the kidney. They just sit there. But they have their own duties. The adrenal corticotrophic hormone. And adrenals tells you it's the adrenal glands. Cortico, just the cortex or covering. Trophic hormone. So the hormones are only going to be from the covering. We call them, easy to remember, these three hormones have to do with sex, salt, and sugar. And to be a little more professionally correct, the sexual hormones are androgens, ANDROGENS, and they have to do with our sexual hormones, the needing production. The salt is mineralocorticosteroids, mineralocorticosteroids, specifically aldosterone, aldosterone is the one that regulates our hydration. So if you ever had a question about hydration in the body, you might consider ADH, but don't forget that the ACTH is governing hydration as well with the mineralocorticosteroid. And then the regulation of sugar is glucocorticosteroids. It's your steroids that so often you're giving in the hospital, because we've been told steroids increase blood sugar. Well, there you go. So glucocorticosteroids are like cortisol. mineralocorticosteroids, aldosterone, and then sexual hormones, androgens. In the middle is the medulla, and the medulla produces epinephrine and norepinephrine. And they have nothing to do with the covering in the cortex. They just live in the same area, but there's no connection with the two. Now, just keep in mind, the medulla has to do with epinephrine, norepinephrine, and you know what that's going to be about, sympathetic nervous system, later. Now, that is the front, the hypothesis. I want to speak just a little bit more about the posterior, where it's storing Pitocin and ADH. Pitocin is not much of a problem. ADH could be the regulation of fluid with an anti-diuretic hormone. And I'm going to tell you, on anti-diuretic hormone, there's no way to memorize. You have to say the word and get some way to try to remember, because it's almost a double negative. And you have to just kind of clear your head and think. And anytime you're on the unit or you're taking state board or anything, you just have to stop and get your head clear. What do you mean by anti-diuretic? Not diuresing, not diuresing. And there can be a couple of problems. You've got too much ADH or too little ADH. So let's go on the idea of too much ADH. If I've got too much ADH, then fluid is all out in my tissue. And and the biggest diagnostic factor in determining if somebody has too much ADH is hyponatremia. You've got low sodium in the blood. The condition is called a syndrome of inappropriate ADH. Syndrome inappropriate ADH, SIADH. Too much ADH. It's known by showing hyponatremia. You know you want a sodium of 137, 138, something like that. When you have a sodium in the blood of 115, that is real significant. You've got low sodium in your body because it's been so diluted that it doesn't show much sodium because you're so full of fluid, because you anti-diuretic hormone is so high, it's kept so much fluid in. Now so it's diluted. Now, the interesting thing is they don't look like the Pillsbury Doughboy. They actually, the people who I've seen with syndrome of inappropriate ADH were packing to go home. They'd had a hysterectomy or a D&C, and they fell and went unconscious. The team came, drew blood. When they found a 115 sodium, they knew it was SIADH. And what in the world do you think would be a treatment? Well, 3% IV sodium. Now you think about your IV that you give normal sodium is 0.9%. That's not even 1% sodium. We need to give them 3% high sodium to get that sodium in the blood back up, because we don't do well with electrolytes that are low. Our heart doesn't like it, nor any other part of our body. So the biggest thing is to give them some sodium and restrict their fluid intake at least about a liter, a quart for the whole shift, so we don't overload with a lot more fluid. Also, tetracyclines. For some, they say they don't even know why they work, but there's desmocycline, DESMO cycline. Your book has it, which is an antibiotic, which they don't quite know why it works, but it will help in excreting some of the fluid. We got to get the fluid off. You're it's called water intoxication. And you may even have decreased in LOC because you've got so much water in your system. The patient, I said, doesn't look like Pillsbury Doughboy because the fluid is so internalized. You know, after surgery, people have trouble getting their ring on and off, but they may not be just look all swollen either, and that's usually who this attacks. Now, that's too much ADH. If you have too little ADH, you have a syndrome called diabetes insipidus. The word diabetes means flow. So don't get it confused with diabetes mellitus, which is the flow of too much sugar. This is diabetes insipidus, the flow of too much fluid, because, now think it in your head, if I've got a low ADH, I don't have much anti-diuresing going on. I'm diuresing. The books say sometimes 20, well, even 40 to 20 liters a day will fly through a person. And see, the whole point of ADH, it keeps fluid in our body long enough to pick up waste, take it to our kidneys, filter it on out. But if we are just, fluid is flying through us, you drink water and it's in 2 minutes, it's urine, it didn't take any waste out. And so what do you think the specific gravity of urine would be with diabetes insipidus? It's probably water, which is 1. And I hope you know from your trusty card what you want the specific gravity of urine to be. We have down on your card 1.010 to 1.030. Well, 1 is water. That little bit of concentration is our waste that's being taken out of our body. You've got to live. It's the only way you can live is that flow of waste going out. Causes, who knows why things happen. Diabetes insipidus can be from a stroke or a CVA or maybe drugs interfered. Some trauma might happen. With this one, you are hypernatremic. Low specific gravity, we said, of your urine. You're polydipsic, you're polyuric, and you're dehydrated, of course. And the treatment is DDAVP, or vasopressin. And DDAVP is all capitalized. You can look in your briefs, DDAVP. And it's an antidiuretic hormone. Or desmopressin will do similar. Allowing the fluid to stay in. A little more anti-diuretic hormone to keep us from diuresing, so that we can hold fluid, pick up some waste, and then take it on out. The next gland I wanted to mention is the pineal, and it has to do with your circadian rhythm, seasonal affective disorder, third eye, jet lag. And they say it is, you've heard melatonin is a hormone that's secreted involving this gland. And supposedly it has to do with light. Light signals the nerves, and the nerve signals the hormones. And melatonin is the hormone that is secreted. Its increase in light, if this increase in melatonin will happen with a low light. Low light, increase in melatonin, increases depression, and decreases gonad secretion. An increase in light decreases melatonin production, lowers the risk lowers the risk of depression, and increases the gonadotrophic secretion, which you're more fertile. In other words, fertility is higher when there's more light outside, related to a decrease in melatonin and low risk of depression. Finland has a period where the country Finland has a period of 20 hours of daylight in a 24-hour period, and during that period, 9 months later, they have high deliveries, labor and delivery numbers. More depression occurs in the winter months when that light is decreased. 30 minutes in a spectrum light, you can get them, they say at Targets for $25 or whatever. 30 minutes of a spectrum light is like 3 or 4 hours of bright sunshine, and it's great for depression. Well, you know, in the winter, a lot of people say they have the seasonal disorder, affective disorder. Now, the next gland I want to bring up is the thyroid gland. Of course, it looks like a butterfly, largest endocrine organ, and has that butterfly shape. And it secretes, we mentioned earlier, T3, T4, and calcitonin, and deals with our metabolism. Incidentally, T4, they say, can be given for depression in women. The thyroid gland must have a little iodine for it to function properly. Small amounts. The best source is iodinized salt. When you buy salt, it says iodinized. And it's probably your best source. Some foods can influence the action of TSH and the thyroid production, like peaches, turnips, peanuts, cabbage, peas, and strawberries can influence and stimulate the thyroid gland to produce more of these, of the T3, T4, and calcitonin. Actually, calcitonin I'm going to talk more about in the, I'm going to talk about high and low calcium, both with this organ and with the parathyroids. I might as well mention calcitonin is the hormone produced, the third hormone, and when the hypothalamus recognizes that your bloodstream has too much calcium, then it tells the thyroid, would you produce calcitonin and send that calcium back to bones and teeth? So that's calcitonin's job, is to take calcium that's too plentiful in the bloodstream and take it to the teeth and bones, where T3, T4 is more in metabolism. Now calcitonin doesn't have a thing to do with hypocalcium. That's the parathyroids. We'll get to that later. I always say when I meet the Creator, and I hope I do, that I want to ask why one organ couldn't regulate the high and the low calcium. No, we've got thyroid regulating hypercalcemia. We've got the parathyroids regulating hypocalcitonin. There is a form of calcitonin that you may give to your patients, and it's called Aredia, A-R-E-D-I-A, Aredia, and it's a calcitonin. So a doctor might give a patient that's low osteopenic, their bone is not as strong or as solid as they want, so they give them a lot of calcium by mouth and then give them some calcitonin that will then take that excessive calcium and take it to bones and teeth and make the person have stronger bones. What about the thyroid when it's too high and too low? And of course, the thing I want you to keep in mind is when you talk about hypo and hyperthyroidism, you're talking about the products T3, T4. You're not talking specifically about TSH. Now, TSH governs it, and you have to keep that in mind. But it's really T3 or T4 when you're talking about too much thyroid. And too much, you know the symptoms of hyperthyroidism. You have increased metabolism, brittle hair, amenorrhea, ammonia in the urine, weight loss, increase in appetite, heat intolerance, hyperactivity, diarrhea, decrease in sleep, and you may have some heart problems because it's making your heart beat so much faster. And I think I mentioned brittle hair. You also, with hyperthyroidism, may have a multinodular, they call it toxic goiter. It's a uniform thick neck. It's what Mrs. George Bush, the older one, had thyroid problems, and her neck just got bigger. It just gets bigger. It doesn't get a knot on it or anything. It's a toxic multinodular goiter, they call it. And why do you get problems? One doctor told me the body has so many antibodies in it, and the thyroid is just a great place to start attacking. And when antibodies attack the thyroid, then it begins to misbehave. And so that could be part of why it starts pouring out T3 or T4. If you have a high thyroid, T3 or T4, and it's so high that you're now getting exophthalmos, your eyes are bulging a little, and you've got the multinodular goiter. If you've got those three things, hyperthyroid, exophthalmia, and the goiter, you have what they call Graves' disease. And they say that's autoimmune, that the antibodies are just fighting and it doesn't have much of a chance. So those three conditions make the Graves' condition. Cardiac, they're going to watch you. If you come in with hyperthyroidism and they think you're doing all right, your heart's still okay, then they may not do a lot for you as long as your heart's okay. But they may give you SSKI, capital S, capital S, capital K, capital I, which is a saturated solution of potassium iodine. And it decreases the vascularity. It decreases the blood flow to the thyroid. In doing that, it will decrease the activity and that extra production of the thyroid. So you may have surgery to get it out, especially if you're getting some heart issues. Or they may start with just SSKI taken by mouth, which slows down blood going to that organ. They may do ablation, where they just kind of burn it and get it to quit working. Of course, you're then put on Synthroid, which is synthetic T3 or T4. I guess it's T3, synthetic. I think I just want to mention the body can go into a thyroid storm, which just means all those symptoms I gave you are going so fast that they're affecting your heart and your entire body. It can be called also thyroiditis, inflammation of the thyroid. So often the thyroid burns itself out. it works so hard, and that's what the doctors usually kind of wait for, so they don't have to do surgery. Because if it works so hard night and day and night, then it burns itself up and it quits working, and so you just take Synthroid and you're done. Now, that's what I want to say about hyperthyroidism. Hypothyroidism, you've got the low amount of thyroxine, and it's more common. And it's just aging will bring that about, as well as the antibodies can do the same thing. Also, treatment for hyper can also make you hypo, of course. Well, look at your symptoms. Metabolism slows down. You get a weight gain, decreased in heart rate. You're hyperpotensive, where with the increased metabolism with hyperthyroid, you were hypertensive. You have a cold intolerance, constipated, increase in sleep, mental sluggishness, coarse hair, and you might get with this a simple goiter. Simple is a unilateral. It's one side is a goiter, has a big bulge in it. The reason for that is, we don't know, again, why do you have hypothyroid? Well, some people, it could be they're not getting the iodine that I mentioned, not in their diet. So they may not be getting that. It may be congenital, that everybody in their family always never has enough thyroid. So it could be that, conditions, thyroid cancer, or whatever. I wanted to speak to the simple goiter, or the goiter that happens with hypo. Now, we've mentioned the goiter that happens with hyper, where it's unilateral. It's bilateral. It's just thickening of the neck. That's your multinodular toxic goiter. But the simple goiter is, and it's not well explained in your book, the simple goiter happens when a perfectly good thyroid was right here, and something, either you didn't have enough iodine and it quit being perfectly good, you didn't have enough, or antibodies started killing it off, but it's not as good an organ as it was. And so you're not putting out much T3, T4, that's hypothyroidism. When it comes up to the hypothalamus says, this isn't nearly enough. TSH, get busy. So TSH just bombards this little pathetic organ. And in doing so, the organ tries so hard to produce more T3, T4, but it's sick. It's either got not enough iodine, or it's been injured, or a virus has gotten it. And so it's working hard, but it's just not putting out T3, T4. But like any muscle, you go to the gym and work a muscle, it gets big. But it's a sick muscle, so it gets big peculiarly. And so it's getting bigger, but it's not putting out any more because it can't. So that's my explanation of a simple goiter versus a bilateral thick neck goiter. This one, the gland itself has a problem. In the hyperthyroid thick neck goiter, the thyroid is being injured, but it's unilaterally working. Bilaterally working. So you have your simple goiter because the sick thyroid's working so hard like a muscle and getting big, but it's getting big peculiarly with a simple goiter. And of course, to check all this, you would check T3, T4, TSH. And Hashimoto's thyroiditis, Hashimoto is inflammatory response, and to a low thyroid. And so often they say it's an autoimmune problem. I just know that you'll see the word Hashimoto's thyroiditis, and it's an autoimmune disorder where the body's own T cells attack the thyroid gland and will work hard to compensate, which causes sometimes hyperthyroidism, but this won't last long because the thyroid gland will get tired and hypothyroidism will happen. And then another condition of the thyroid is myxedema, and it is hypothyroidism as an adult. myxedema, myxedema, when you get hypothyroidism as an adult. And of course, if you're hypothyroid, your metabolism waste builds up, and it could be a lack of iron again. The heart muscle might get flabby. You have all those conditions of hypothyroid I told you you're getting it as an adult, and it can be life-threatening. If you have hypothyroidism as a baby, you might have the syndrome cretinism, cretinism, cretinism. And you may have studied that when you had your OB-PEDS course. The children, if you work in well baby nursery, they can tell the cry. It's a hoarse, deep hoarse, like they've got a cold cry or upper respiratory problem. They do have respiratory distress. It's hard to get their temperature above 95. They're lethargic. They don't nurse well. And so they usually draw a PKU, which can tell if they're having problems in that area. The next organ I want us to look at is the parathyroid. And they're 4 little raisin-sized glands right there on the thyroid. They're the size of raisins. There are 4 of them. And they control calcium, hypocalcium. Remember? Thyroid and calcitonin regulated hyperthyroid. The parathyroids are going to govern the hypothyroid. In other words, your blood goes up to the hypothalamus. The hypothalamus says, uh-oh, too low in calcium. Alerts the parathyroid hormone glands to produce PTH, parathyroid hormone, which goes out now and pulls calcium out of bones and teeth. So we have enough to supply and have that connection with nerves and heart, mainly our biggest muscle, nerves, muscles, that synchrony that we want. And that's what they do. The hyperparathyroid hormone is just an increase of PTH. And I don't think you need to learn a lot, or just know what the word means. Hyperparathyroid, hypoparathyroid, which is very rare. And so just keep in mind what the parathyroids do. Hypocalcemia. And of course, the treatment would be calcium supplement, usually calcium carbonate or calcium glutamate. And remember the calcium that we need. Every serving of calcium, glass of milk, is 300 milligrams. And we want 1,200 premenopausal, 1,500 postmenopausal, and you know your body doesn't do well with over 500 in 5 hours. So nobody wants to take 1,000 because about 500 of it went into the commode. it can only deal with 500 every 5 hours. So if you take 750 calcium glutamate or whatever, take one in the morning and one at night, and that's your 1,500 if you're menopausal. And then I think, why don't we go on to the adrenal glands, and here they are, and small caps on top, no relationship to the kidney itself, and I've already talked about androgen, mineralocorticosteroids, glucocorticosteroids, and what they do. Now, knowing that, what we've talked about, and the 3 hormones that come off the cortex, I do want to mention a pheochromocytoma. Pheo, P-H-E-O, chromocytoma. And it is a small benign tumor that's only found on the adrenal gland, and it's usually sitting on the adrenal gland, but it pushes on the medulla, and it may push on the cortex too. But its big symptom is high blood pressure, hypertensive. And I always say, if somebody goes to a doctor and the doctor says, "Ooh, you're hypertensive," and gives them a drug, or sends them back in a month and they're no better, they usually try another drug, another hypertensive drug. Well, they don't do any better. Then the physician needs to scan them or check to see if they have a pheochromocytoma. It is benign, and that's a good thing. And it just needs, you just go in and just, the doctor told me, you just pull it off like the petal on a daisy, and just comes off, and you're fine. Doesn't even hurt the function of that adrenal gland. A CT could find it, some kind of scan would find it. They might put you on a VMA, and the V stands for vanilla, and then mandelic acid. You don't have to know all that, just VMA diet or test. 24-hour urine, and you all know about 24-hour urines. If we start at 9 o'clock, they empty their bladder and you throw it away, but you write on your jug 9 o'clock, because that urine was made before 9. Now that you've emptied the bladder, everything that's made is since 9 o'clock. That's a pet peeve of mine, that nurses started at 9 and put the 9 o'clock urine in the bucket. And that 9 o'clock urine was made before 9 o'clock. Tomorrow morning, 24 hours later, the last urine does go in the jug. So 24-hour urine, and the patient should really abstain from any vanilla product that vanilla might be in, and no chocolate, and fruits and tea, caffeine, and some medications may have vanilla in them. And if they have higher than normal VMA, then they probably got a pheo. You know, you can see a tumor with a scan, but is it malignant or not? Well, if VMA test 24 hours shows this high pheo, that high VMA, they'll know it's a pheochromocytoma. Good news. Want you also to be familiar with the test 17 keto and 17 hydroxy steroids. Again, 24-hour test, and they say it determines the activity of the cortex. They're just seeing how good is the cortex working. 17 keto and 17 hydroxy steroids. Now, studying the adrenal gland, we have already talked about there's several areas of the body the sexual hormones enter in. Steroids, we're going to talk about. This mineralocorticosteroid, or the salt that balances our fluid. If you'll just keep in mind the The salt has to do with our hydration, our salt, because salt determines our hydration and our fluid. And you say, well, ADH, it does several places. Our Creator took care of us in several areas of the body. And then the sugar will be an emphasis on our cortisol, and we want to really emphasize that. I want to mention Cushing's disease, which is an increase in cortisol. Now, it might be from they give you by mouth the Cushing's, the cortisol. I want you just to keep in mind, it's a list in your briefs of all the things that steroids do to us. Keep in mind, it makes us hyperglycemic, and with and that we can get, if too much steroids, you get a buffalo neck, you might get a moon face, you don't heal well, your tissue is thin, you're more prone to infections, you are hypertensive, you may be hirsutic, which is hairy, hirsuism, remember that, Hirtusim, hirsuism. Hypokalemic, hypernatremic, sodium, so low potassium, high sodium. And a woman might be amenorrheic, no periods. Hypocalcemic, so they maybe have osteoporosis. And the treatment will probably be to get rid of the adrenal glands, because that's what's pouring out the cortisol. So keep in mind everything that high steroids do. And that's, even though you may not see a lot of Cushing's disease, you'll see in the hospital some issues that show too much cortisol. Ooh, blood sugar's high. And they're not even diabetic. What's that about? So think of all those things. Then Addison's is too little cortisol is produced. Addison's. So your cortisol level is down. And so with that, you have some opposites of the other. You have hypotension, hyponatremia, and hyperkalemia, and hypercalcemia, muscle weakness, anorexic, and a poor response to stress because you don't have the stress chemical. I'll talk about that in a minute. Lethargy and depression, emotionally labile, and you may have some hyperpigmentation. And see, they could run a 17-keto and a hydroxy 24-hour urine and see the activity of the cortex and see, ooh, it's down, you probably have Addison's. I consider cortisol, I call it C, as in the alphabet, ABC, C to the third power. Of course, the treatment for for Addison's would be cortisol. And it's C to the third power. I say cortisol is the coping chemical. Cortisol, the coping chemical. When you're in stress, our cortisol pours out. When you're under pressure, cortisol pours out. If you don't have it, then your homeostasis gets off kilter, and you may go to an arrhythmia. When you see a car accident and your stomach goes up in your throat, it's your pour of cortisol that keeps your heart beating properly and keeps you from going into an arrhythmia. Wonderful chemical that keeps us in good shape. But if we don't have it, then we've got to do something about that. Sometimes a person may get too much cortisol because they're Addisons, and then they have iatrogenic Cushing's. Iatrogenic, I-A-T-R-O, iatrogenic Cushing's. In other words, iatrogenic means that they got it from a treatment. Their Addison's was too little. We've over-treated, and so iatrogenic means we gave them Cushing's. And you'll see that not just in this illness, but with others. There may be the treatment causes the illness. I wanted to mention, you may wonder, why do I have to give cortisol? Why not give ACTH? And the answer is ATH is IV or IM. It's IM. I think it can be both. But it's a much bigger deal than just taking a pill. And so these pretty well can be taken care of elsewhere in the body. So do we want to give shots and somebody out in the world getting shots all the time, or take a pill? Now, I've very simplified it, and in class we're going to talk about that a little bit more. I want you to think about the fact that, steroids are anti-inflammatory. That's one of their properties. Look in your briefs, anti-inflammatory. You taper them off. You don't just quit steroids, because remember, they're the coping chemical, and if you take the bottom out of your coping mechanism, you might go into an arrhythmia. Retards cell growth. Your cell tissue is thin. Ulcerogenic. You get ulcers. Either on skin or inside your body, you'll get an ulcer. Too much steroids. Hypercalcemia, hyperglycemia, increased appetite, decreased healing. Skin can flush. Now, if somebody had ulcerative colitis, that's an inflammation of your GI system. And okay, let's give them steroids, and that cuts inflammation down. Why do you tomorrow go to clinical and you're told to give a shot plus PO cortisol? And you say, well, both of them will increase the anti-inflammatory effect. But I want to say, then give just more of this. Let's don't give that shot. Let's just give more of this. And I hope you're saying to yourself, if I give too much of this, it goes up to the hypothalamus, and the hypothalamus says to ACTH, you don't have to do any more stimulating. She's taken care of this forever. And so we begin to atrophy. If you're in the hospital, say several weeks, and you're taking huge doses of this, ACTH is not called upon to stimulate, because you're doing it all by mouth, and you're going to atrophy. So you may get over your ulcerative colitis by PO cortisol, but you just atrophied. So they give this so it keeps stimulating the cortex to stay alive. I hope you understand that, and if you don't, bring it up in class and we'll talk about it. Now, just a word on hypertension. Sometimes cortisol will cause hypertension, and just know that treatments can cause hypertension. Primary essential hypertension comes on quickly. Primary essential elevates very quickly, usually happens 20 or 30 years of age. Secondary hypertension, it's due to another disease process. Secondary hypertension, something else is causing the hypertension. And of course, hypertension crisis may be affecting the renal system. I always say blowing out the nephrons. If you're keep in mind hypertension. I'm not sure we give it as much respect as we can. When that blood pressure is so high that it could rupture neurons or rupture nephrons, we're in trouble. And so treat it with great respect. The next gland I wanted to mention is the thymus, and it produces our T cells. We'll get into that in immunology, but they're associated with your your immune system process. The illness that you probably learned in peds was the DiGeorge syndrome, D-E-D-I, George syndrome, where children have down slanting eyes. They're without the T cells. Usually they don't have the thymus gland. Poor immune response, heart defect, high arched palate, not enough antibodies, not enough T cells. The last part that I wanted to mention is the pancreas. And the pancreas is the size of an adult fist. And you know the islets of Langerhans put out insulin when needed. And then that insulin carries sugar over into the muscle. It's, some people call sugar a coal, and the shovel is insulin, puts the sugar over into the tissue. And there are other hormones in the pancreas. You already know about the digestive enzymes that don't have anything to do with our insulin production. I do want to mention that those 4 enzymes you learned in peds have to do with cystic fibrosis and the digestion of children. And don't forget that, because those, you can have cystic fibrosis and have problems with those digestive enzymes. I also wanted to mention pancreatitis, an inflammation of the pancreas, and so often it's from high ingestion of fats or liquor that have carbs in them, high carb. And the pancreas just gets inflamed. It's working so hard. The best treatment is to rest it, and it usually will calm down if rested and given fluids that don't work it so hard. I think that's what I want to say on a lot of times TPN, the total parenteral nutrition is given. They may put an NG tube down just to rest the stomach and keep fluids out of the stomach. NPO, and of course no spicy fluids, no fat, no caffeine, no alcohol for pancreatitis. Now just to center on the diabetic part, the pancreas is supposedly a little larger in women than in men. And I want you to keep in mind on the cells. This was explained to me. Our cells, normal people, have 4 chambers where sugar can get in. And you can go through life and that works great. But supposedly, if you're inclined hereditarily, you may get type 2 diabetes, and you probably have a cell with only 2 entries. And you can imagine that it's a little harder for insulin and sugar to work as efficiently in a 2-chambered cell as a 4-chamber. And there are a lot of reasons that you can get secondary diabetes. You can have antibodies, you can, they say that probably an antibody does injure the pancreas, the flu, or something, anything could injure those islets of Langerhans. And the production's down. It may still be producing some insulin, but not enough for your livelihood. I know a fellow that said he abused his body pre-adolescence, drinking lots of Cokes and not as much exercise, but exercise worked. And he was able to get through pubescence. But when he got into adulthood, his exercise went down, he still loved the Cokes, and the demand and the supply of insulin just couldn't keep up. And when it can't keep up, then we get our blood sugar increases. And they serendipitously, which means by accident, discovered that the glands of the Gila monster, it looks kind of like an iguana, out in Arizona, they noticed it could go 6 months or 6 weeks without eating. So they investigated it, dissected it, and found that its saliva gland had a hormone that slows digestion. And they decided, why don't we give that to diabetics or type 2 diabetics who could slow their digestion, and then the blood sugar will stay up with the demand. So that comes in the form of Byetta, B-Y-E-T-T-A. It's given twice a day, and all it's doing is slowing your GI absorption so that our little piddly amount of insulin can take care of the slow digestion and the sugar that comes from that slow digestion. We also have a new drug, Victrola, look in your meds, Victrola, and it is the new Byetta just one time, Victrola, I think. Remember, when you've got high sugar in the blood, the little motto is hot and dry, sugar's high. Cold and clammy, eat some candy. Hypo and hyper. I don't care that you learn all the symptoms that go with it. Usually if anybody doesn't feel right and they're diabetic, you can pretty much, you can always give sugar. And so keep that in mind. Sugar doesn't hurt the brain. Lack of sugar does hurt the brain. So any treatment for a diabetic that you don't know which is, you always do sugar, and I know you've heard that before. The HG1AC, which tells us how much the red cell lives 120 days. Sugar, when you eat, kind of clings to a red cell, and the life of that is 120 days. In 90 days, they check your H1AC and see how much you have been collecting, and so there's where you can't just stop a month and be good. That's it's a telltale of how good you have been eating by the red blood cell and the amount of sugar collected on top of it. And so that's your H1AC. You want about a 6. And keep in mind, the life of a red cell is 120 days, but they do it about every 90 days because they don't want to get so close to the death of the red cell. And whole blood glucose. And you know how that's checked. And your sliding scale. A lot of times the doctor gives it to you. Blood glucose minus 100 divided by 15 or 20 or whatever is telling you how much you do give of that insulin. You roll your insulin bottles, whatever they are, not to mix. You're mixing, of course, but it's to keep suds. You could do this and mix, shake, but it makes suds, and I can't accurately measure. It's the only reason that you're rolling instead of shaking something. Remember clear to cloudy. Clear is regular insulin, so you put air in the cloudy, air in the regular, clear, draw the clear up, and then go to cloudy and draw it up very carefully. You need to know your insulins, and you've got your card that you want to keep up with, And keep in mind, we'll talk about in class, if you are given insulin, a certain kind, when are they peaking? Are you concerned they're still high? It peaked. They shouldn't have been this high. That's what we want you all thinking about. 70-30 insulin is a mix of 70 NPH, 30 regular. Big deal to know that blood sugars have to be gotten before they eat. Now, they can start eating and you give the insulin. That doesn't matter. I mean, you say, well, they got a little high blood sugar and before I gave the insulin. That does not matter. What matters if they ate before you got a blood sugar. That's an absolute. Blood sugars before they eat. Once they start eating, you can give the insulin. You don't have to break your neck to get to the room to give the insulin. But I want you breaking your neck to get the blood sugar before they eat. And if you mix an insulin, you've got about 5 minutes before you give it. And some of the fast-acting, you want to have the breakfast right in front of them. And know their peak times. Bedtime, people who have 24-hour insulins need to get a snack. And you have it on your card, and I hope you're learning them so that you don't even need your card. Who needs a snack at night? And regular insulin, the only insulin that can be given IV. Like 70-30 insulin is a mixture, but they have a stabilizer in there. If you're doing the mixing, this needs to be done in the 5 minutes that I mentioned. Remember, Humulin is human-like. It was made in a lab, so it's like human insulin, and it's a trade name like Campbell's soup. So don't be thrown. It's Humulin N for MPH, Humulin R for regular. And if you open a vial to use it, you need to put the date on it. They say in about 30 days it only loses about 1% potency, but it's still a good thing to do. 1 unit of insulin will lower whole blood glucose 50 points. A diabetic needs to wear a bracelet. Have sugar with them. What's the best thing if somebody is having a reaction? They need sugar of some kind. If you just have sugar, put it under their tongue. They need to watch their weight, their sores on their skin, their vision. If you have a patient, ask them. Part of a care plan would be ask them how their vision is and have they seen some deterioration. Neuropathies, diabetics, so often that circulation is interfering with the capillaries. So keep in mind neuropathies and the retina, the eye situation. Remember the dawn syndrome between 4 and 8 in the morning? Blood sugars are a little higher. Dawn, D-A-W-N syndrome. Blood sugars are high during this time. If somebody is fasting, I think they say the blood sugar is about 100 when if you're fasting, or certainly within normal. Keep in mind the 3 P's: polyuria, polydipsia, and polyphagia if you're a symptom of diabetes. And DKA is blood sugar is about 200 to 300. And Kushmal breathing goes with metabolic acidosis. Keep that in mind. And diabetes, too, is the blood sugar for HHNK, hyperglycemic, hyperosmolaric, non-ketonic syndrome. You don't have to know all that. Just realize they're really up high. If in diabetes too, it can be 600 to 700. If any diabetic is in a coma, we assume they are hypoglycemic and give sugar. Because even if they're hyperglycemic, it's not going to hurt. And we're going to talk more. I want to talk about carb counting, and so you might want to review that. Remember, one carb will lower the, one carb will increase the blood sugar 50. And diabetics can do about eat anything they want to if they realize that they need to count carbs. An active person can do 4 carb servings, and each carb serving is 15 grams. So 4 carb servings at breakfast, 4 at lunch, and 4 at supper if they're very active. 1 carb serving as a snack. So this active man usually has 14 carbs, but that's 15 grams. And I want you to get things, we'll talk about it in class, where your hand just gets the movement of looking at the serving at the top of the item, and then how many total carbs. That's what I want you to look at, total carbs. If it's 30 grams, then that's 2 servings and of carbs. That's 2 of your 4. Women, so often, they say about 2, 2, 2 with the snack in the middle. And that's 15 grams. A few examples. So 1 serving of carb, a unit of insulin can bring down. A unit of insulin can bring a carb serving down. Orange juice, your 120 orange juice is 1 carb serving. 1 banana is a carb. An apple is a carb serving. 3 teaspoons of honey is a carb serving. 5 lifesavers, a carb serving. 17 grapes, a carb serving. 8 ounces of milk, 1 carb serving. And then look, there's 3 things on a label. I want you to look at how many servings, because they may have 2 servings in that whole thing, but the total carb is 1 serving. So it had 2 servings, but my total carb was 15. This thing has 30 in it because it's 2 servings. Total carbs are always the 1 serving. Always, the other thing I want you to go down and look at, total fiber. And fiber can be subtracted from total carb. So if you had 15 grams total carbs and 3 of fiber, you just had 12 grams of carbs. Or we'll talk more about it, but that gives you an idea. Get these things in your mind along with your insulins, and we'll talk about it in class, and see you then.